However, he was like, I am really interested in talking with community leaders and local hospitals about how they can set up their own program that's similar to ours. So kind of like a mentoring program for communities to build similar programs. Talk about barriers, challenges, how they sought out funding, all of that. So just to know that we are going to continue these conversations. So if there's things and you're like, okay, cool, you talked about this thing, but we don't know how to get it here, write that down, and that's something that we can follow up with in the future. So just want to remind folks that today is not the end of the conversation, it's meant to be a beginning. All right, and with that, I'm going to turn it over to our next presenter, who has a great presentation.
Thanks for your confidence, Shannon. Hello, I actually asked Shannon not to introduce me because I feel like that's the weirdest part of this for some reason. But I'm Jessica Alfaro. I'm the Director of Residential Services for Crossroads Turning Point. I work in the Pueblo office. I directly supervise the women's pregnant and postpartum women's treatment programs, but I also oversee the men's IRT, intensive residential and transitional residential programs, as well as the other women's intensive residential and transitional programs, as well as the STIR programs. So today we're going to kind of focus on the substance use services and specific things for women. I am going to look at a quick ASAM overview and levels of care, just to kind of give you some background on what residential looks like and what outpatient looks like, but I don't want to spend a whole lot of time on it because I want to talk more about what our programs offer. Keeping that in mind, we have some very specific gender factors and services that I also want to discuss. Women who are pregnant and postpartum obviously are a very specialized population. So I want to make sure that we really touch on some of that. And again, like I said, talking about the programs, PPW IRT is the pregnant, parenting, pregnant, postpartum, women, and then the intensive residential and transitional residential. And last is, why is this important? Why is treatment so important in all of the things that we've talked about the last couple of days? So ASAM. In order for us to decide where we should place these men and women, we conduct an assessment, a multi-dimensional assessment, has 6 dimensions, and the focuses are intoxication and withdrawal, biomedical conditions and complications, which for this population would be pregnant and postpartum. Dimension 3, emotional, behavioral, cognitive conditions and complications, so mental health, cognitive, maybe developmental, things that are going on that may complicate their time in treatment. Dimension 4 is their readiness to change, so really looking at how ready are they to make the changes that they need to for long-term recovery. Dimension 5, relapse, continued use, and continued problem potential. And dimension 6, the recovery and living environment. So it's not just about living in a home that doesn't have substance use, but it's also about living in a healthy home, not having toxic relationships with parents, siblings, children, but having a healthy recovery living environment and what that looks like. So each box, I won't go through each one of them, but you can read what each one focuses on. So we use all of those. So we utilize all of those to decide which level of care is most appropriate for these women. So up on the screen, we have the primary levels of care that we work with. Crossroads is one of the only programs in the state of Colorado that serves all the continuum. So we serve residential, we serve outpatient, And each level provides different treatment, provides different therapeutic contact hours, different activities, different focuses. So on the left-hand side is our flow chart that we kind of utilize to determine what's going to be most appropriate for the patients that we're talking about. So if current intoxication or risk of withdrawal, they're either deciding whether withdrawal management is the best place to go, or if they can go straight to an assessment. And then the assessment determines which level of care. So on the top, we have the CIRCLE program, which is our medically managed, high-intensity residential. And then in that first column, and then on the bottom of that column is regular outpatient. So if you notice, the assessment has all of those arrows pointing to each one of those levels. Each level has a step-down process. Now, they don't necessarily have to go through each step to be successful, but the longer they're in treatment, it increases their chances of staying sober and staying in long-term recovery. On the top right-hand side are other areas of our focus, which are intensive case management and OTP, which this is the whole point for our summit for the last couple of days. So, of course, I'm here because I specialize in residential treatment, but I also understand that not everybody fits in the box of residential, not everybody needs it, and not everybody can make it through that type of level of care. And so, understanding that, the ASAM helps us determine not only where we think we are assessing these patients at, but also where they want to be. So sometimes that's different. Sometimes we feel like absolutely residential would be the best place for them. And that may be true, but they may not be capable of doing that. And so making sure that we provide as much education on each of the levels of care that we determine is most appropriate. So residential, positive things, having a full-time facility that provides a supportive environment to help them recover without temptation. Outpatient services focus on helping people understand their addiction as well as their triggers and reasoning for using substances, but still having the ability to be out in the community. And then talking about education on addiction, recovery, how changing their thoughts and behaviors, life skills, and identifying those triggers, developing plans to combat those triggers and cravings. So all of those things are important in treatment, which even more so self-care, relationships, and having a plan for their sobriety and recovery. Okay, so as we know, we have both men and women in this room. We are very different than our counterpart, right? We have a lot of different, our brains are different, the way that we interpret life is different. And so wanting to make sure that when we look at treatment for women, specifically mothers, that we take those gender-specific issues into consideration. So relationships and the influence of the family are really big. Honestly, more often, women receive less support from their family or partners when trying to get sober than men do. And I thought that was an interesting statistic because it almost feels like it would be the opposite with the women that we work with every day, but we have more men who are supported by their families versus the women that do. Does anybody have an idea why? Go ahead, Jen.
Stigma.
Stigma. I love it. Yes, stigma. And it comes with like parenting moms, pregnant moms. You know, even though Rob's doing my arrows over here and switching the slides, he's given great presentations on how difficult it is for women who are seeking harm reduction services, who are pregnant, who have a belly, but are asking for clean needles, or disposing of clean needles, or asking for maybe STI testing, or different things that that women have complicating their lives in recovery. Let's see, women have a tendency of having trauma that treats them differently than the men. And then pregnancy and postpartum, right? So because we talked about stigma, pregnant women not only don't want to come to treatment, but they also don't want to get medical treatment either. They struggle with going to the doctor every day or every appointment that they have because of maybe the way the nurse treated them, or the secretary treated them, or unfortunately even the doctor and the way that the doctor treats them. And I would love to say that we have worked through all of that, but we still really have a lot of forward motion we need to make in the medical field. And then the women have a tendency of suffering medical conditions quicker than men. So they develop liver issues quicker. They develop maybe high blood pressure quicker than their male counterpart. And so the complications of their medical stuff, for lack of a better word, it just starts to happen quicker, unfortunately.
I have a quick question on that.
Sure.
So you're talking about the statistic of women not being supported, obviously. Do you see a higher disproportionate based on race as well? Because I would think culture would play a big factor, so that more women, say, who are Hispanic, tend to have a harder time than women who are of a different race or ethnicity.
Yes, actually, that's a great point. Yes, they do. Pueblo is primarily, we got a larger population of Hispanic, and so it follows right through with that. You know, Hispanic families, I'm from a Hispanic family, and so as an oldest Hispanic woman, I have unwritten rules that I have to follow as that person. How I should carry myself. How Anna said earlier, pulling myself up with my bootstraps, dusting my knees off and getting up, and there's nothing to cry about, right? And so, yeah, we definitely have a lot of pressure, not only the pressure that we put on ourselves, but the pressure that communities, our families put on us as well. And then it goes into stigma and bias, which we already talked about. Stigma is such a huge problem. All the way throughout the United States. It doesn't matter whether we're in Colorado, Arizona, Massachusetts, we have issues everywhere. So on the other side, we have those specific services that kind of go hand in hand with the specific factors that we need to take into consideration. So care coordination, which is why intensive case management is so important. Getting them connected to a primary care or an OBGYN, and getting their children connected to pediatricians. Getting them connected to specialists if they need to. Co-occurring services. Co-occurring is a lot more helpful for anybody that has a co-occurring disorder, but getting integrated treatment. Not having to go to one place for this and one place for that and one place for this, but being able to do it all in one place helps with their specific needs. Parenting education and parenting responsibilities. And so I would love to say that women get to go to treatment for 30, 45, 60, 90 days and focus on themselves and then go back to the home and try to be a sober parent or try to be a sober daughter or a sober partner. And the hard part is that they've literally been focusing on themselves for 30, 45, 60 days, and now reintegrating them back into maybe where exactly they came from is a complicating factor. And so that's why, for me, parenting on the unit, hands on the unit, helps them learn how to get sober and be a sober parent as well as a sober person. And they do that together. And then, of course, MAT services. We've talked about it for the last 2 days. They are vital in recovery for people who have opioid use disorders. Okay, so this is the picture of our PPW program in Pueblo. And so one of the reasons that I I put this picture up here is because I think people have a tendency of thinking that treatment centers look like jails. That they're scary, that they have bars on their window, that they, metal detectors as you walk in. I mean, you name it, there's lots of misconceptions about what treatment programs look like. But I would have to say that looks like a fairly, I mean, maybe we need some more water in the grass, but I would have to say it looks like a fairly normal campus. And so, one of the things that we were able to do, I wish I would have been a part of, but my executive team was able to obtain a SAMHSA grant, which is specific to pregnant and parenting women. That allowed us to expand our services. We were already doing a women's residential family center approach, but this grant that we were able to obtain helped us expand all of those services. So we were able to get a women and children's coordinator who specializes in not only working with the children who are working through each developmental stage, but helping moms work on breastfeeding if they've just given birth, or all of the things that kind of come with new moms. Sometimes medications, sometimes C-sections, sometimes issues with their partners, things like that. Vocational specialist. She helps them create resumes. We talked about a lot of these men and women in this population and really the lack of maintaining some of those documents that they need to have a job, that they need to apply for housing, like birth certificate, ID at the very minimum, social security cards. And so our vocational specialist, because you need all of that to actually apply for a job and get the job and start working at the job, she starts working on some of that stuff in our IRT program, but she really hits it hard in our TRT part, because they aren't going to be able to make any progress without some of that. We have an interventionist. So that interventionist will go to the hospitals, will go to court during shelter hearings, to be there to provide any type of answers that either the lawyers, the patients, the family have about treatment. And really encouraging the moms and the dads to enter treatment if they're ready for that. And then a licensed behavioral health clinician. So we have a co-occurring counselor on the unit. She's able to work through maybe crises that come up or issues with parenting, communicating with their kids, communicating with their peers, working through their trauma. And so it helps that she's there so that if she has to intervene with any type of mental health crisis, the patients don't have to go far. Hands-on parenting education with the Women and Children's Coordinator. So they do parenting on the unit with the kids in group. And so they get to have those sober activities that they're teaching their kids, art activities, things that, depending on the age, is super engaging and works on that bond and attachment with parents. Again, we talked about care coordination and case management services, and minimizing the barriers to treatment and outreach to the outliers. So focusing on Los Animas County, Huerfano County, Otero, all of those kind of outlying areas that we talked about that have very minimal treatment options. We want to make sure that everybody knows that we have the ability to do residential. Down in Pueblo, or up in Pueblo. So this kind of goes specifically through our PPW IRT program. It's clinically managed, but high intensity. We do not have medical staff on the unit. However, they do have access, and we try to set them up with primary care. If they come from counties that are not Pueblo, and they want to return to those counties, we work with medical professionals in their areas, because we want to make sure that if that's where they're going, we get them as many resources as we can to set them up for success. We're looking at 30+ therapeutic groups and recovery-related activities weekly. So that's group therapy, that's life skills, that's parenting, that's introduction to 12-step meetings, smart recovery, all of the things, giving them a little bit of each to help them find out what's going to work for them. Let's see. Mothers have the ability to bring their children, ages 5 years and younger. They can bring multiple children. I think this last winter we had a mom with 5 kids on the unit, and she took care of those kids, all 5 of them, better than some of the moms taking care of one. She was just an amazing, amazing mom. And when she was sober, she just flourished in everything she did. The kids were respectful, they were helpful. I wanted to hire them, but they were not old enough to work for me yet. And so, you know, she was just a really great mom. And she was able to leave after, I believe, 90 days of treatment. She still has all of the kids. She's working a professional job. Her significant other also got sober, and he's working a professional job. So it was really nice, not just to see the mom get sober and mom be a parent, but father be engaged as well. And that's why the family approach is so important. We do consider kids ages 6 to 8, depending on what kind of space we have, their schooling needs. So we're headed towards summer. That's a little different than maybe during the school year. But when we get patients from Pueblo, we help transport to school. We help pick up from school. Sometimes we help the moms help the kids with homework, depending on what the need is. But really just trying to help provide as much support as we can while they're with us. And then the last one, pro-social activities for families. So taking them to the movies, taking them bowling, reintroducing them into sober fun. You know, I think a lot of people in this population use because they're bored. And so teaching them that it's totally okay to go and bowl 80 at the bowling alley and still have fun with it, because that's pretty much what I bowl. And then introducing them to the 12-step meetings. In Pueblo, we have Addict to Athlete, we have Celebrate Recovery, we have Smart Recovery, some of those things that are as common in other areas. So that's one of the dorm rooms. We have a pack and play. She has everything that she needs for the baby. At that time, the baby, I want to believe, was about 10 weeks, maybe, I would say 2.5, 3 months. Mom is close by. That was her bed right across from the pack and play. And then if you see on the other side over here, this is a side sleeper. And so really promoting safe and healthy sleep, because often, as you moms know, it's extremely difficult to get up into the middle of the night and feed the baby, change the baby. And so the side sleeper really helps not only mom, but helps the baby as well. Let's see. And then access to peer services. We will have a peer on the unit, starting today, actually. And she completed the PPW program. So not only does she know what treatment looks like at Crossroads, but she knows what treatment in the PPW program looks like at Crossroads. And then, of course, like I said, accessing the co-occurring services, therapy, medication management, all of those needs. So the TRT program is transitional. It is all of the things above in the IRT program, but also helping them transition back into the community. Sometimes kind of the way I look at it is you have this really big step of IRT to 3.5 level. And if you don't step down, I don't know if anybody's ever missed a step before, it kind of feels like you fall down to the next step. And sometimes it can feel like that when you're navigating recovery in the community. And so a clinically managed low-intensity treatment program, the level 3.1 helps them slowly transition back in. They have a curfew, they have to be back at a certain time, because as I say, nothing good in Pueblo happens after 6 o'clock. And so, okay, NA meetings are after 6, but everything else after that, nothing happens good in Pueblo after that. But still focusing on treatment. They have 10 to 20 therapeutic group hours a week. So they're still expected to get up in the morning, take care of kids, get them ready like if they were going to a job every day, Monday through Friday. But at the same time, making sure that they know when it's time to slow down, when it's time to have self-care, and using the weekends for those days. Those are family days. Those are having dinner with grandma days. Those are spending time with significant other and kids. That's what that focus is. And then Monday morning, being able to hit it again like a regular job. So we continue to address the case management needs that we talked about earlier. Childcare and is definitely a desert in Pueblo, unfortunately, just like it is down here. And they had CCAP on a hold for a while, so we weren't even able to enroll new moms into CCAP. They got exempt from it. And so it makes it even more difficult for moms who don't have childcare to find a job and to be able to sustain that job. Back down to the vocational needs. And so some people want to further their education, some want to find a job, but being able to help them with some of that stuff, having job searching verifications, providing interview clothes, doing practice interviews, asking them questions, giving them an opportunity to answer, be dressed up, and practice what they will say and do in those interviews. And then recovery meetings and activities, focusing on some of that. So, continuing the specialized needs, this is a very narrow picture, but what this is called, we've named it the Milky Way. Pretty sure we stole that from somewhere. But it's our lactation room. So being able to have a room specific away from the cameras. We have a chair back there, some pictures that are positive about moms and babies, and just giving them the ability to sit in a quiet area and either breastfeed or pump. And it's almost like a quiet room as well, allowing them to just kind of decompress if they want to. So I think for a long period of time, I was hearing a lot of kickback on breastfeeding, especially with moms who have just had a baby that was drug exposed, substance use exposed. And so there's really been a switch though in the physicians, in the presentations that I've been to. They're really pushing breastfeeding as long as the substance is no longer in the mother system. The specialized need for women, self-love and self-esteem. Often they come to us without any of those. And so helping them rebuild them, that's gonna be best for them. And one of the big things right now is contingency management. Being able to provide something positive for negative A's, I don't know what that is, but being able to provide something every time they provide a negative UA, not just an A. So we do weekly UAs. If they hit all of their group hours for a week, they get a punch. And every time they get a punch, they get to pick from the fishbowl. So the fishbowl can range from women-specific things like hygiene, maybe some Dove body wash or new makeup, something like that that's gonna help them feel better. Or they can pick from a fishbowl that's more focused on the baby. Maybe they have a baby who started teething, so they have teething rings, they have teething tubes, all of the things that a mom who has a baby that's teething could benefit from. We also have maybe Nike outfits, Adidas, name brand things that they wouldn't necessarily be able to get on their own or have access to. After 5 punches, they get to pick from the $50 prizes. So baby swings, baby baths, things that are a little bit more expensive. And they get to take these things home. And then the last one, after 10 punches, they're looking at $100 prizes, cribs, side sleepers, bassinets, pack and plays. And so as long as they keep working through the program and keep maintaining negative UAs and keep attending group and doing the things that they need to do, they get to walk out with some of those basic needs that they have when they get their own place, or if they're returning with their family, just kind of helping with some of those things that they need to get them set up. So why is it important? Why are we here? Why do we need these types of treatment programs? Rob says it all the time, and the way he says it is just crazy, but dead people don't get sober, right? Shannon said that very nicely, wherever she is. It was very nicely delivered yesterday, but he's very transparent, and so I have a tendency of doing the same thing. But yeah, dead people don't get sober. We have the ability to get women who are pregnant or who are early postpartum into the program within 24 to 48 hours. So we have started working with Parkview, and often the behavioral health program will call me on my cell phone and be like, I just had a mom who gave birth. She's open to treatment. When can you come get her? And we will go pick her up from the hospital. And if Pueblo County DHS gets involved, which often they have been, intake workers, as long as they have a good safety plan, are helping them transition right over to Crossroads. And then when the baby gets out of the hospital, baby gets to join. And so there's really no time in between mom and baby bonding. If baby stays in the hospital longer than a couple of days, we take mom twice a day in to visit baby for feedings, for diaper changes, for any type of procedures that they have. And then they stay for several hours, helping feed, helping change, helping do skin-to-skin contact, things like that. So it's really helped us just continue on the process. They get exposure to evidence-based practices, counseling, positive peer supports, meetings, and all of these things can help increase their chances of long-term recovery. I found that women who have their children in treatment increases their retention, not just in treatment, but in specific residential treatment. So they stay longer, if not completing the program more often, and they have better treatment outcomes in the long run in most of the major areas: health, mental health, medical, all of those specific areas that they were lacking before they gave birth. I talked about this, but they have minimal time and in between that bonding, and so they get to keep working on that bonding every single day with their child. If they want to breastfeed, they're given that opportunity. Unfortunately, with Colorado, overdose for pregnant and postpartum women is the second leading cause of death. And that's not just overdoses, but that also includes suicide as well. And so really taking into consideration how specialized this population is and the needs that they have, if we want them to recover and get sober. And so one of the things that we worked with Safe Baby, when Safe Baby first came to Pueblo, is that we were seeing women getting into treatment much faster. And like I talked about, the quicker they were getting into treatment, the longer they were staying, as long as the child was present with them. And that helped us lead to more case closures with success, with parents retaining custody or maintaining custody of their children, and really increasing reunification, but minimizing the foster care utilization. Because mom got to keep the baby with her. If both parents go to treatment at the same time, because we have the men's program, we coordinate with counselors and the men so that the fathers also get their own time. So moms have the kids on the unit throughout the week. They have a family day where they visit with mom, dad, and kids or child. And then on the weekends, that is dad time. Dad takes care of the kids by themselves. So they get to have their own bonding time with their dads. They have a playground out there, they have activities, toys, really not focusing just on the mom and the baby, but the family. I think that's it. Yep, that's it. So that's what our program looks like, and that's where our focus is. I see you have a question. I think Shannon's headed for you.
You didn't have to run, trust me, they can hear me like buildings over. I don't so much have a question as a comment. This has got to be one of the most hopeful, uplifting things that I have seen. That so often I think that when there are mothers who are addicted, the focus is entirely on the child, which it should be, I get that. But we're not gonna get good outcomes for anybody if we don't care about the life of the mother. But to do this as a family and to provide the support, this is hope personified. Thank you for the work you do.
Thank you, I appreciate that. And you're right, this is hard work. Sorry. I was looking at the staff that I have, and I believe that 7 out of the 25 staff that I have are all in recovery. And they all have professional jobs. So only one of them is a peer out of those 7. The other 6 are either like entry-level positions looking to start certification technician classes. They want to become counselors. They want to go back to school. And they get to give back to the population that they spend the most time with, right? And so it's just been amazing, not just to have them come back and work for me, but come back and give back to the program that they took so much out of. Go ahead.
I have 2 questions. What happens if, because we've been talking about how relapse is part of recovery, so if a mom relapses, do they get kicked out of treatment, or what do you guys do?
No. That would counterproductive, right? They are in treatment because they have an addiction, a dependency on a substance. So we would be kicking them out for what we have them there for. It just doesn't make any sense. And so we work with their lapse. We work with their relapse. We help them develop a safety plan. Because we work so closely with Pueblo County DHS, if they have a kinship provider or somebody who does respite, baby will go there for a day or 2 while mom works through the lapse, works through maybe some icky feelings they have from the use that they had. And then baby comes right back. And that's if baby leaves. Because sometimes all they're getting out of the lapse is maybe a hit. Maybe one very small line if they can get any powder anywhere. And so just taking into consideration, is it a safety risk? Are they right now at risk? And most often they're not. They have 19 other women who believe me, hold each other accountable. They're like, Susie's in the bathroom for too long, I don't know what she's doing. Or Mary's nodding out, I know she's on methadone, but you better just check to make sure. And so they help each other. They hold each other accountable because it's not just about their kids, but it's about the kids on the unit in general and their safety.
One more question. If you are working with a system like child welfare and they need a special plan that if mom's gonna leave, the baby doesn't go, do you guys work with stuff like that to make sure the baby stays safe?
Yes, so we create our own safety plan on the unit. And the safety plan says, this is what's going on, you're involved with DHS, or this is the entities that you're working with. maybe it's even just family. If you want to leave treatment, these are the steps that we're going to take, which would be, we're going to contact your caseworker. You are going to talk to your caseworker and let them know the decision that you want to make. And then that they understand that the child is not going with them. The child stays with us until the caseworker comes for them, which sometimes usually takes anywhere from like 1 to 3 hours. It's never anything crazy. But the child stays with us, and the mom signs something saying, I understand that if I make a decision to leave this program, I want my baby to be safe, and so these are the steps I'm willing to take to keep the baby with me, so that not only can that entity feel better, but I can feel secure in having my child with me during treatment. Does that answer your question?
Yeah, thanks.
You're welcome.
So I actually have a comment and a couple of questions. So when I started with Crossroads, I was hired on with the expectation that I would help get the recovery residents started here. When we started, it was for women. Biggest roadblock was a lot of women with children couldn't bring their kids with them. And as soon as we switched it to a men's residence, I have those beds filled with that. So I appreciate that we're talking about the roadblocks that women have when it comes to entering into treatment and even recovery residents. You know, the fears that CPS will get involved. What am I going to do with my kids? Where are my kids going to go? So I do appreciate that, you know, we're touching on that. So Pueblo Crossroads has the women's recovery residences. Neither of those residences have the option for children, do they?
They do not. And I will tell you, he's already rolling his eyes. I have been asking, begging, you know, short from getting on my knees for a recovery residence for women and children. And so I'm hopeful that my team, my executive team, has heard me, but you're absolutely right. That is one of the biggest issues. We only have one recovery residence in Pueblo that does do women and children, and it's an Oxford home. But I'm really, really hopeful that my team will hear me and see the needs that we have in the community and work towards finding somewhere that we can have women and children in that recovery residence.
Awesome. And my second question, I guess, is more geared towards Rob. Is there any plans for a women's residence in Trinidad?
That's a good question. So there's a lot of things that, where did Ryan from the BHA go? So I'll just say this. So I want to answer the women with children thing. Jessica's been on me about opening a recovery residence for women and children. There's so much more than just opening a residence for women and children. We got to look at liabilities. We got to look at childcare. We got to look at staff to run that. So we know it's a need, and then we also got to look at sometimes, and I'm just going to say it from like a straight up standpoint. Do we help 9 women who need a place to live, or do we help 1 woman with 4 kids? Right? It's like we start measuring it out. How does that work? What is more important? Right now, one's more feasible than the other. Just to keep you in the loop, we did apply for a grant to turn the apartments on the side that are connected with our PPW program. We have apartments there. We did put in a grant to turn those into women with children units because they would be connected to our treatment center. And then we would open another women, just recovery residence for women off campus. I think that's about the safest way we could go about it, so we are trying to do that. And then back to your other question about what we're doing in Trinidad. So the state has, so see this, I'm just gonna, do you care, Jess?
No.
Okay, so see this is the ASAM, right? And Jessica has in here, she has the 3.2, our withdrawal management is 3.2 over here on this square. So this is changing because Colorado is going to adopt a new ASAM. So this will change a little bit, and when that changes a little bit, social detoxes and withdrawal managements will undergo a change. And with that change, we know that we're gonna do 3.1, 3.5 level of care with withdrawal management. And that's not a secret, that's the state pushing this with a withdrawal management component. If the state does that and they switch that, if they flip that switch, we're of course gonna do that. So an all women, no. Co-ed, possibly. So that's what we would be looking at. So hang in there. I know it's like we are literally waiting for all the changes too. And ASAM's sitting on it real close. You know, the state hasn't decided exactly when. It's going to rock our system and change the whole system. And so we don't know when that's going to go into place. But I'm going to say something I just want to point out since we're on the ASAM. And I want to say this. It's so important for judges, probation officers, parole officers. I was talking to Marty earlier. I recently wrote a book and spoke at CCJC, and I've had mixed feedback about it, but we need our staff to do an ASAM, and then they need to follow with what the experts say is the level of care they need. Nothing is more harmful than putting someone in the wrong dose of treatment. And I talk about it in my book so much, and it's the thing that just seems like everybody gravitated towards, but we get calls from moms that need a break from their 31-year-old sons, and they're like, he needs residential. We get POs that say he needs residential. We get judges that say they need to go to residential. What we really need them to do is do an ASAM and comply with that. That's what needs, so we want the right dose of treatment. We need the right dose of care. It's not always residential. That could be more harmful. And sometimes when we treat somebody with the hardest level of care, there's nowhere to go after that if they have a bad experience, right? They might be thinking like, I went to treatment, I didn't learn anything, it sucked. Yeah, because you didn't belong in residential treatment. Now I know with children, it gives a different dynamic and there's a safety issue, but it is so important that I just can't imagine going to the doctor and I'm like, I hurt my arm, he's like, we're gonna cast it. Like, why? He's like, because your mom said we gotta cast your arm, you broke it. I'm like, are you gonna do an x-ray? No. Cop said he saw you, gotta cast that arm. Like, we need an assessment. We need to assess the situation, just like it's medical. We look at those dimensions, are they gonna withdraw? If they're gonna withdraw, they're not going straight to residential, right? Nobody wants to try to learn algebra with food poisoning. That's what it would be like. You know what I mean? Like, who's had food poisoning in here? So withdrawing is like that. I have lived experience. Withdrawing's like that. Could you imagine you're sitting over the toilet, you're throwing up, and you're yelling at the restaurant, and somebody's like, 12 divided by 6. I need the answer, right? They're not going to want to talk about cognitive behavioral therapy while they're withdrawing. So that becomes an aspect of it. Same thing with emotional. All of these dimensions are there for a reason. It's a medical model. We need to make sure everybody's getting into the right dose of treatment. And so, I just want to make sure that everybody understands that, because Jessica's a lot nicer than I am, and she's so positive. And then, but honestly, then she's like, you gotta call this BO they're trying to do. No, I'm just kidding. But we really do. This is a challenge for us, and it's a challenge for our clients. This group, even us, we have such strong biases, and we perpetuate stigmas. I can't tell you how many rooms I've been in where everybody's like, I just don't agree with harm reduction. And at the same time, like, I've walked out and seen their Facebook page talking about, Ozempic is the greatest thing that ever happened to me. I'm like, Ozempic is harm reduction, right? Because you could flip that. Why do you need methadone? Just stop doing drugs. Just stop doing it. Why do you need Ozempic? Just stop. Just change. Right? So there are so many forms of harm reduction in our society that we are ignoring. Pepsi, Diet Pepsi is harm reduction for Pepsi. If you don't know this, they're both poison. It's not water, it's not tea, it's coffee, it's poison. People like me in the health industry, I'm not like, oh, Pepsi or Diet Pepsi, you're gonna die, you don't deserve the help. I see what you're drinking, right? We are in a society that reduces harm all along the way, and I think for whatever reason, we associate with what's legal and what's illegal with what's moral and what's immoral. Some of the values, the laws have changed. Like, if you don't know, there's no felony drug possession under 4 grams. Fentanyl is a game changer. But some of those things, society's changed, but we haven't let go of our biases and what we associate with that. And what we want may not be what they want. Do you know what I mean? And so just really take that into consideration. Start with the conversation they're willing to have, and then hopefully they have the conversation they're not willing to have. But when we try to do it all at once, we just push away from it. So I just wanted to say that. I'm glad Kat asked a question so I could take Jess's microphone and talk smack.
He needs to talk smack about me, just in case anybody was wondering. Any other questions that you guys have?
I just have a comment to follow up on what you just said, and I think another aspect of, I think another level of that treatment that you're talking about is we're putting them into the wrong treatment because we generalize it. It also applies to adolescents and children, right? So working in residential treatment facilities for as long as I did, working with those kids and knowing that some of those kids, yes, needed that kind of intensive therapeutic service, but there were many youth and adolescents that we put into RTFs, RCCFs, whatever you want to call them, that really should not have been there, and we did more harm for those youth than we did help them. So I think that's an important factor to keep in mind when we're talking about the types of services or intervention strategies that we're using to get at any age.
You know, I want to say something too. You talked about family support. One of the things that we see a lot in Pueblo, and I talk about this a lot when I do presentations, I come from a Hispanic family and I have lived experience. Right? Sometimes the most dysfunctional thing can be the families that are overly involved, right? So it's not always the ones that don't have support. Sometimes it has it's the family that won't, like you're like, I'm ready to ride the bike, and they have the training wheels and they're holding the seat. And they're telling you what you need to do. I've literally been yelled at by more dads over their family members being on methadone than anything. And it's a weird conversation to be having when they're like, I don't want my son or daughter on the street, but then they're yelling at me because they're on methadone. So sometimes it's not just the lack of, it's the overwhelming involvement.
That's a great point. Anything else?
Any questions on mine? All right, well, thank you guys. And really good work. And don't go too far away because we're hoping that some of you will be on our panel later to talk about barriers and challenges and opportunities. But guys, we got a bit of a break, so you guys can have about a 10-minute break. We're going to get started again at 2 with Marty from probation. We're going to talk about some probation services and judicial impacts and recovery services.